I'm Dr. Monica Parker. By training, I'm a family physician or primary care doctor. I've been a primary care geriatric doctor at Emory's Geriatric Center, since 2001. What we now know as the have come to learn as the Geriatric Center no longer exists in its former form. And so now this is my new avocation, which is kind of trying to make sure that older adults are as knowledgeable as they can possibly be about what we need to do to age healthfully. And for those of us who have a little problems with our brain and how the brain functions, try to help you understand how you can make sure, make sure what you got is still working like it needs to work for the next 10 to 20 years. And if you're dealing with somebody who's already got a little brain dysfunction, try to help you manage that a little bit better. So I want to clear up some myths around here. What's the difference between normal and abnormal brain function? What's the definition between Alzheimer's and dementia? Are they the same thing? What's mild cognitive impairment, and how do you diagnose Alzheimer's, and how do you prevent it? How many of you here think you've got good brains? How many of you think it's functioning like it's supposed to? Raise your hands. I don't see everybody's hand going up. Okay? How many of you are taking care of somebody whose brain doesn't work quite the way you think it needs to work? You kind of like rudderless, kind of like going around trying to think you're crazy too? Okay, and you are, all right? I say that because I take care of my mother, who's 93, and she's got advanced dementia. It's a mixed kind, as you're going to learn through here. And I also take care of her 91-year-old sister, who doesn't think there's anything wrong with her. So I'm here, I'm representing certainly the medical profession, but more importantly, the Emory Alzheimer's Disease Research Center. It's sort of like, well, why are you going to talk to us about research? We need help. Because if you don't participate in research, we're never going to get a cure or a better understanding of what this brain dysfunction is, what causes it. And what I can tell you is in the 15 or 20 years since I've been doing geriatric medicine, is that what used to be something regarded as something of an inevitability is no longer that way. Okay? All brain dysfunction isn't inevitable. A lot of it's preventable. In 2017, the Lancet Journal came out with a report that said that 32% of all dementia, that's all dementia all over the world, could be prevented if we managed our lifestyle differently, if we lived a little bit differently. And how did we learn that? We learned that through research, through study of people that were healthy and people who were not so healthy. What I will tell you is that a lot of the research that we've learned about Alzheimer's doesn't pertain to everybody in this room. Most of it doesn't pertain to women, certainly not women of color, but most of the research has been done on men, okay? Now, why is that important? Because a lot of what we know about any disease state is dependent upon who is studied. So if you are a European American man, chances are the medicines, and I can tell you this for sure, most of the medicines in your medicine cabinet are going to work well on you. They may not work so well on a European American female, and they certainly won't work as well on an African American female. Why? Because these medications weren't studied in those people. That's why we are a strong advocate in our center for getting as many people as possible to participate in Alzheimer's research, okay? Why is this important? How many of you are familiar with the Women's Health Initiative of like the 1980s? Okay, that was the study that showed why it was important to start, let's say, calcium supplementation in women because you wanted to prevent osteoporosis. That was the study that helped us understand that heart disease was different in women than it was in men. Okay, so we've done a lot of things that are a little different as a result of research. So research participation, certainly medical research, regardless of what the disease entity is necessary to be studied. Different diseases manifest differently in different groups of people, different ethnicities, and different genders, okay? And that's why we need you to participate. Research nowadays versus 20, 30, 40 years ago is largely a safe process in the United States anyway. I can't talk about every place else because here most research is conducted in a university setting or an academic research setting where we have something called an institutional review board. And this review board is composed of doctors like me, some academic people, but mostly people like you. Why? Because if we're going to conduct some research, we want to make sure that it's safe, that it's ethical, that your personal privacy is protected, and that more importantly, you're participating in a study that you fully understand and are fully vested in. And if you're not, you shouldn't be. Okay? So let's talk about Alzheimer's. What we know about Alzheimer's has changed in the last 10 to 15 years because of research. Right now, we know that Alzheimer's, of all the diseases on this list, stroke, asthma, arthritis, obesity, cancer, the only one on this list that has no cure or definitive treatment is Alzheimer's. Okay? All of these diseases lead to a lot of sickness or morbidity, but most of these have some type of cure associated with them that's effective. Alzheimer's does not. Alzheimer's is the 4th leading cause of death for African Americans 65 years of age and older in the United States. Annual health care costs are greater than $226 billion, and that's largely because people with dementia are managed by providers and in hospitals and given treatments, if you will, or diagnostic tests more specifically, that are unnecessary. A lot of people with dementia are hospitalized unnecessarily. Caregivers. If you are a caregiver, and I am one, there's a lot of unpaid caregiving that goes on. We estimate that that cost is about $217 billion, and that's not so much what you would get paid if you were taking care of your relative, but if you are a caregiver who's a working caregiver, and you have to take your mother or your father to the doctor, and there's nobody around to do it, who does that? And if you work, what happens? You lose money. Okay? So as a caregiver, this is expensive because, not so much because this is what you would get hourly because you are taking care of your relative, but because of what is necessary to manage that person's care. I'm a daughter. I have 2 brothers. They live in different states, of course, and they don't have custodial care of my mother, so I'm the one who takes care of her. When the caregiver doesn't show up that I've hired for the weekend, doesn't show up for her $15 or $20 or $26 an hour, who takes care of her? Even after she leaves, who takes care of her? It's the caregiver, right? So you miss a lot of vacations. But more importantly, Alzheimer's is going to cost us more money in the short run than it in the long run, simply because many of us are living longer, and most of the people who have a brain dysfunction aren't unhealthy. Their brain isn't working, but they're mostly healthy people. So who gets Alzheimer's or dementia? Most commonly, the people who are nearly 50% of the people over the age of 85 are going to have Alzheimer's. But in this little age group here, 75 to 84-year-old people, maybe 20 to 30% of them may have some type of brain dysfunction. I didn't say Alzheimer's, did I? I said brain dysfunction, didn't I? Okay? That's because all brain dysfunction is not the same. We estimate right about now that we have about 5.5 million, it goes up all the time, about 5.5 people greater than 85 who are affected with Alzheimer's have this, or Alzheimer's, we should say Alzheimer's and related disorders now. But by the year 2030, this is going to be more like 70 million. So this particular slide is important because, as I said, 4th leading cause of death for African Americans, 6th leading cause of death for European Americans, but the people most likely to die from Alzheimer's, is green stripe represents the females. Now, and we're more likely to die from Alzheimer's regardless of what our ethnicity or color is, not so much because we live longer, but because this disease manifests in women differently. It shortens our life expectancy a little bit longer, but more importantly, what we're learning in research, and Danielle talked about some of it, we're finding that there are gender differences in how Alzheimer's and other dementias manifest in women or develop in women. Here in Georgia, we have about 150,000 Georgians who are affected, who have a diagnosis of Alzheimer's. We really think there's more like 500,000 people in the Georgia area that have Alzheimer's and related disease. Here in the southeast and southwest corners of Georgia, we have the highest incidence of dementia from all causes, but this also correlates with the area of the country, or of the state, excuse me, that has the highest incidence of cardiovascular disease. That's a research topic. There's a connection. We're trying to better understand the connection between cardiovascular disease and brain disorders. Here in DeKalb County in Metro Atlanta, we have the highest concentration of persons diagnosed with Alzheimer's or a related disorder. In Georgia, 50% of all Medicare recipients have Alzheimer's or related dementia. 92% of the persons who have an Alzheimer's or related dementia have at least one chronic disease. Most Medicare recipients with Alzheimer's or a related disorder have at least 4 chronic diseases. So these chronic diseases kind of put you at risk for developing a little bit of a brain dysfunction. What are they? We know that we have a 20-year history of high blood pressure, well controlled or poorly controlled. There's a 20-year history of hypertension that's associated with the onset of brain dysfunction, diabetes, cholesterol. I call this the triumvirate. High blood pressure, diabetes, and cholesterol are major risk factors for strokes, right? But the strokes are also a major risk factor for a brain dysfunction, vascular dementia. Okay, heart disease, chronic kidney disease, anemia, rheumatoid arthritis, depression, COPD, and heart failure. All of these chronic diseases usually are present in somebody who's been given a diagnosis of a type of dementia. By contrast, 20% of those people who don't have Alzheimer's have only one chronic morbidity. What does that tell you? The sicker you are, the more likely you are to have something go wrong with your brain, right? So when should we start working on this? I'm looking at some of the young people. I'm looking at that one right there in the back. She looks very youthful. We're starting to look at Alzheimer's and related dementias as a life course disease. It's not something that just happens to you when you get old. It's something that you have to work at starting early. Not so much teenagers, but like even younger. How many people know about the recommendation for football for people under the age of 15 and 16? What's the recommendation?
Don't do it.
Don't do it. Now, why don't we want you to do it? Right. Okay, that's research. Okay? If you have grandchildren, you know, in the Northeast, and I'm from Connecticut, they have very few people coming out for tackle football. Football has changed up there. We're getting to it in the Southeast and SEC nation. Football is a contact sport. Lots of head trauma, head injuries, kind of sow the seeds, if you will, for later brain damage. You know, you've heard of chronic traumatic encephalopathy, the football player's disease? Okay, that stuff starts early. So instead of getting your kid in contact football early, it's like, let's get them to be a little bit more formed neurologically. Let's get them to their teenage years before we start playing football. And if we're going to play football rather than contact football, it's touch football. They had a big study, documentary news coverage on 2020 a couple of months ago on how persons of color are the ones that are still playing contact sports. Persons of color and poor people are still playing contact football versus others, okay? Again, keep in mind what you do early on. Again, we're looking at brain dysfunction as a life course disease, so how you take care of yourself from the time you're young to the time you get to middle age. Now we're focusing on not old people with this disorder, we're focusing on what people can do in middle age. Middle age being, I'm going to be generous here, somewhere between 45 and 75. How about that? Okay? And I'm saying that because a lot of us, you know, I know how old I am. I don't feel as old as I am. I mean, I was jamming coming over here getting lost, but getting mad slamming after the trucks too. Okay? I do want you to understand that, again, keep in mind that brain dysfunction is something now that we're learning through research is a life course problem. What is dementia or neurocognitive disorder? Dementia or neurocognitive disorders are not normal aging. Just because you get to be 90 doesn't mean that you shouldn't have brain function, okay? These are persistent symptoms. They don't go away. It's not temporary. The important piece right here is right this moment, there's no effective treatment for it. I don't care what you read. I don't care what you hear on television. I don't care what somebody wants to sell you. There is no treatment for any neurocognitive disorder. That's something like Parkinson's, that's ALS. Those are neurodegenerative disorders, okay? There's nothing we can do to bring back dead brain tissue or damaged brain tissue, all right? Now, some of the symptoms of dementia or a neurocognitive disorder kind of overlap with acute illnesses, okay? Acute illnesses, things like urinary tract infections and pneumonias, fevers, high fevers in older adults, or even kind of like a chemical, delirium related to medications that don't interact well with each other in a certain individual. Medical delirium is a medical emergency, but more importantly, these things are fixable. You can fix a urinary tract infection, right? How? Right, you get some antibiotics somewhere, but you got to recognize that you got a UTI, right? All right? Then there are people who take different medications, and that can make them crazy. Okay, but that's something that can be reversed. So delirium is a treatable medical problem, and usually when you treat this medical problem, the delirium goes away, and when the delirium goes away, the confusion goes away. You've probably seen people who've been admitted to the hospital, and things change, right? Okay, so what is a neurocognitive disorder? What is a brain dysfunction? So in medical terms, there are a lot of things. When we think of dementia, we always think of memory loss, right? But your brain helps you do other things. So in our neighborhood, in the medical field and in behavioral science, your brain helps you do a lot of other things. These are the different functions that your brain helps you do. Complex attention, which is the ability to attend and process multiple stimuli. You're looking at this PowerPoint presentation. You're hearing me, right? You're looking, you're reading, you're trying to interpret what you're reading, right? That's complex attention. That's a brain function. Executive function, the ability to plan, to organize and complete tasks. The ability to program your GPS to get lost in Cobb County. That's a brain function, right? Learning and memory are pretty self-explanatory. We understand that. You know, who my children are, where I am, using the right words for the right things. Perceptual motor. Manipulating things. I've got a pointer in my hand. Do I know how to use that? Okay, that's a brain function. Coordinating my body to move from this part of the room over to here. That's a brain function, folks. So and language. Okay, we understand language. We understand social cognition. This says socially appropriate behaviors and decision making and empathy. All right? None of us would say, if I weighed 300 pounds and stood up here, you wouldn't say, come right out and say, Dr. Parker, you're fat, would you? Because that's socially unacceptable, right? But somebody who's lost the ability to regulate themselves, if you will, wouldn't have any problem saying that. My mother doesn't have any problem saying that. She tells me that all the time. Anyway, the point of this is your brain helps you do something other than remember words and to learn something. These are the domains. These are the things that your brain helps you do. Your brain helps you with complex attention, executive function, learning and memory, perceptual motor, language, and social cognition. So depending upon what part of your brain is affected or what part of your brain is damaged, you're going to have areas in these difficulty with some of these areas, right? That's part of the brain dysfunction, okay? That's part of what goes into dementia. By definition, if you have abnormalities in 2 or more of these areas, we tell you you have dementia. It doesn't matter to me that you get up and put your clothes on. To me, that's a good thing. And to family members, that might be a good thing. But if you can't manage your business affairs, if you can't prepare your meals, if you can't organize your activities such that you get where you're supposed to get when you're supposed to be there and require somebody else to help you, by definition, you have dementia. Do you understand what I'm saying here? Okay? So it's more than one little thing that gives you dementia. Okay, what are the different types of neurocognitive disorder or different types of dementia? Okay, the Alzheimer's Association has given us an umbrella. I'm going to give you a pie chart in the middle. But the most important thing is all of these things are a type of dementia. Alzheimer's disease, which is most commonly diagnosed, vascular disease, which results from like strokes, long-standing hypertension, and diabetes, a mixture of dementias, which can be combinations of all of these, Lewy body, which you heard about with Ted Turner. I'm going to use him all the time because he said famously, I have Lewy body dementia. It's not as bad as Alzheimer's, okay? The problem with any of these is the end stage result is you can't do anything for yourself. Somebody else has to do it. Somebody has to get you up, somebody has to get you dressed, somebody has to toilet you, somebody has to feed you, somebody has to protect you. Okay, it doesn't matter what the cause is. The end stage for all of these is the same. Okay, so you've got Parkinson's disease, which is a movement disorder. Alcoholic encephalopathy, okay? We like to think of alcohol as kind of like a legal drug, but it has a legal toxicity, and most people, my father used to say, well, you know, all of us have a drunk relative of one sort or another. You have a drunk uncle, you have a drunk aunt, but you know, this one's always suffering from the DTs. I never knew what the DTs were until I went to medical school, but these people have drunk so much that they black out. Their brain doesn't function, okay? Alcoholics get a type of brain dysfunction or a dementia. And then there's the chronic traumatic encephalopathy that we've talked about, which has to do with trauma. Here's my pie chart. You can substitute this as an umbrella. Dementia is the broad term, but underneath this you have different types of dementia. Alzheimer's is most commonly diagnosed, followed by something that's a mixture, which can be Alzheimer's and vascular, or Alzheimer's and Parkinson's, or Alzheimer's and frontotemporal, or Alzheimer's and alcoholism, okay? So you can get a type of dementia that's associated, or brain dysfunction associated with all of these things. Most commonly diagnosed as Alzheimer's because that's the one we have the most research on, but as research proceeds, we learn that all of these things result in a type of dementia. Okay, what are some of the dementia symptoms? Okay, I've talked about memory loss and I've talked about brain function. People worry about people who repeat words, stories, phrases. People who all of a sudden don't recognize that they have to go to the bathroom, to urinate and to defecate. That's a neurologic function, isn't it? How many of you have grandchildren you're potty training? Some people are stubborn and no, you can't train somebody to potty train at 1 year, more likely 2. Okay, 18 months to 2 years is the optimal time to train people for toileting. Why? Because now they recognize the sensation of urination and defecation. The thing is to get them to do it in the right place at the right time, right? Same thing with older adults. As they develop a brain dysfunction, they no longer recognize when they have to toilet. That's why they're urinating in the wrong places, or they're getting soiled and they never why didn't you tell me? I'd have gotten you there. How many caregivers have had that experience? You get frustrated. If you just told me I'd have done this, now it's all messed up and I gotta go clean you up, I gotta clean up the house, I gotta clean up the car, I got a mess, all right? But don't get mad. They didn't know. They don't recognize. I need you to understand that. Defecation and urination control is a neurologic function. That's a brain function. So when you develop dementia, you don't recognize signs and symptoms, more importantly, what you can do about it. How many of you saw the movie Alice? What is the movie? Julianne Moore, okay? Remember when she was at her beach house and she said, I'm gonna go in and go to the bathroom, and she got all frustrated, and then you noticed that she urinated on herself? Okay, that was partly because she got lost in her house. She was trying to get to the bathroom, but she couldn't find it, so she ended up wetting herself. That happens to a lot of older adults. Those of us who have relatives who live in their own home, they're where they know the bathroom is, if you're in the same place for the last 50 years, chances are you're not going to have as much of a problem with that as if I take you out of the home you've lived in for 50 years and move you to your daughter's 5,000 square foot home with the master suite. You don't know where the bathroom is, so you can't get there on time. You might know you need to go to the bathroom, but you don't know where it is now because you're in unfamiliar surroundings. Okay? Gait instability and falls. Okay? People like to say in older adults we fall because, you know, we have some unbalance, we're physically incapable, or we've taken too many medicines and we're going to fall. But the cerebellum is what kind of controls some of that motor activity, and the cerebellum shrinks, right? So 2 years before most people have a formal diagnosis of Alzheimer's or dementing disorder, they're going to have a little trouble with how they walk and how they balance. All right? Personality changes. Some people become very, very mean. Some people become very, very sweet. As their dementia progresses, some people may develop some psychoses, some abnormal behaviors. They answer the door with shotguns. You know, they don't recognize people. They do unusual things. They hear things, they see things. Some people really do have weird things going on, but you never can tell with somebody who's psychotic, right? And sometimes people who have an underlying, if you had schizophrenia when you were 40 and 50, when you get to be 75 and you have Alzheimer's, you still have schizophrenia. It's just different. Okay, what are some of the dementia behaviors? As a clinician, most people don't mind people being a little eccentric and a little crazy, but this wandering bothers them, especially when it comes late at night. You just get up and you wander outside the house and you don't know where you are. I've had patients whose daughters have been asleep in the house and their mothers walk out the front door right here in Cobb County, as a matter of fact, and they're in a neighbor's yard, or they knock on a neighbor's door. Okay, they wander while everybody else is asleep. They may have personality changes, the paranoia, they may hallucinate, they may have unusual behaviors. All of a sudden, some people are meticulously clean, so they clean all the time, they throw things out. Some people are the opposite, they hoard things, right? How many of you know hoarders? Most people who are hoarders have something going on up here. So don't think they just like to keep things. My mother's thing was to keep those little trays from the grocery store that your meat comes in. She'd rinse them out and stack them up really neatly. She liked those, and she liked plastic gallon bottles, and she filled them all up with water. And she didn't want you to throw any of those things away. Okay, compulsive behaviors, driving difficulties. I used to practice in Social Circle, Georgia, and lifelong resident who was in her 90s. You only drive up Highway 11. There's only one traffic light in Social Circle. She got lost. She was going to the beauty parlor, which was on Highway 11. She lives on Highway 11, and the beauty parlor's on Highway 11. She got lost. Driving difficulties. I had some family members who had to go to Charlotte to pick up their relatives because they got lost, and the mother and the daughter argued in the office because the mother said nobody would let her get off of 285. They wouldn't let her move over. The traffic was bad. And they argued. But the daughter had to go to Charlotte to pick her up because she ran out of gas on the side of the road. And the police brought her to the hospital, notified next of kin, and her daughter went to Charlotte to get her. People get lost. Okay, so what's mild cognitive impairment? It's you have some problems with some of those brain functions, but it's not interfering with your overall function. Instead of having two or more, it's only one of those higher brain functions we talked about before. So when you have mild cognitive impairment, and you're going to hear that more and more, and it seems really a little bit more scientific than I think it needs to be for the average person. So, well, she's got MCI. Well, if I'm not at Emory or some other place that studies this, I don't know what the heck MCI is. All I know is she has one or two things that go wrong, but for the most part, my relative can take care of herself. She can go to the bathroom, she can keep the house clean, she can feed herself and prepare her meals. I might need to start looking at her books, but she overall is able to function by herself. The important thing about recognizing mild cognitive impairment is whenever we start to develop whenever we develop a cure, this is going to be when we want to start using it. It's like cancer. The sooner you can detect it, the sooner you can fix it, right? Okay, mild cognitive impairment is sort of like where you have to start looking a little bit more closely at what's happening to somebody. Mild cognitive impairment is not always associated with Alzheimer's. It can be associated with something else, but most people who have mild cognitive impairment related to Alzheimer's may certainly progress to dementia. But if you have mild cognitive impairment because, let's say, you had a benign tumor in your brain and they removed it and you're okay, but you have one or two things different from the way you were before, you're probably not going to progress any further. Okay, how do you address things that you see that are abnormal? Let's go back to these symptoms. Okay, these behaviors, the wandering, the personality changes, maybe even some of these symptoms that you see here, how do you address them? Well, you need to get to a doctor, some doctor. And maybe you don't like the doctor, and if the doctor's not listening to you, I always tell people find another one, okay? But you, when you go to see that doctor, need to be very clear about what it is you're seeing and what it is you're observing and what it is that's making you uncomfortable, because regardless of who that doctor is, they can't help you unless they know exactly what's going on. Granted, all primary care doctors aren't associated with Emory or the Emory Alzheimer's Disease Research Center, but almost all of us are qualified health professionals, and we can certainly look for things that can be treated, you know? Some of us are taking medications incorrectly, and a lot of older adults are taking medications incorrectly. They're taking them correctly, but they don't react well in them. You know, a dose for an older person is a little bit different for somebody who's younger because we don't metabolize things as well. Some people will have some normal behaviors, some behaviors may not be normal for these persons. But more importantly, you need to address the problems that you're observing with a trained professional. And when you're starting to deal with somebody who has a brain dysfunction, it's not only your doctor you have to deal with. Who else do you think you have to deal with? When it comes to money, who do you have to deal with? Huh? Insurance, but how do you deal with insurance? Okay, let's just say I get ready to die. Who's the person who has to do a will? Your attorney, right? Okay, you need to know something about how to manage the affairs of somebody who may be affected. It's important while I'm in my right mind to get my durable power of attorney for healthcare, my durable power of attorney for finance, and if I have some property somewhere, it's important for my children or my husband, whoever it is who's helping me with things, understands where the deeds to all of that are. Ever heard of heirs property issues? Lots of people can't inherit property that they've lived in for generations and generations because there's really no clear title and deed to the property because nobody took care of that. Well, grandmama's lived on this farm for the last 50 years, but nobody can find a deed to that farm, right? Lots of people in Louisiana after Hurricane Katrina lost their property. Lots of people in Florida are losing their property after hurricanes because they're living on family land, but nobody has title to it. So when you start dealing with somebody who has a brain dysfunction, it's important to get those business affairs in order. And it's not always a family member who is the person who's best suited to do that. You need to see a trained healthcare professional, a doctor for ruling out medical problems, a lawyer, an elder care lawyer to help you manage affairs. I mean, we've had lots of people whose relatives are just writing checks and writing checks and writing away all the family inheritance. But the children don't know, do they? Until there's a crisis. So what are some of the risk factors for brain dysfunction? There are only two things up here that we can't do anything about: living longer and our genetics and our gender. So yes, as relates to Alzheimer's and to some other diseases, genetics do play a role. We know commonly that there are two specific genes that are associated with Alzheimer's, something called ApoE4 and in African Americans, ABCA7, but there are almost 30-some genes that have been identified as associated with Alzheimer's disease. Research has discovered this in the last 10 to 15 years, that there are different genes in different people. Some people have familial Alzheimer's. Early onset Alzheimer's is Alzheimer's that starts before the age of 65. Late onset is after 65. So when you see early, like I'm walking around here, I'm 65 and I can't talk straight, is that early or late? That's really kind of like late, simply because early is before 65. So what are some of the risk factors? Remember I said that there are 9 things that you can do to prevent overall global dementia? Okay, stroke and cardiovascular disease. This is a major risk factor for a brain disorder or vascular dementia. 60% of all people who've had a stroke end up with dementia. What are risk factors for stroke and heart disease? Atrial fibrillation, heart failure, there's that hypertension again, and high cholesterol. Okay, untreated mood disorders. Untreated depression masquerades as a type of dementia. Pseudodementia, we call it. This can be screened for and treated. Substance abuse, I've gone into alcoholism. Tobacco, what does tobacco have to do with Alzheimer's? Tobacco is a risk factor for vascular disease. It exacerbates or accelerates the atherosclerosis or hardening of the arteries that may lead to having a stroke. Okay, medication interactions. As I mentioned earlier, there are some medications that older adults take that they probably shouldn't take, or even if they're taking them correctly, may interact badly and cause symptoms that go along with dementia. Some of the cardiovascular drugs that we take for heart failure and atrial fibrillation do have side effects in older adults that may manifest as cognitive dysfunction or brain dysfunction. Chemotherapy. Is there such a thing as chemo brain? Yes, there is. Okay? When you finish your chemotherapy, will your brain result back to normal? Maybe, maybe not. But it is a real thing. There is something that causes that. Benzodiazepines. I call these the happy pills. Xanax. Anybody heard of Xanax? Okay. You've heard of Ativan? Okay. For the people in the 80s and 90s, in their 80s and 90s, you might think of something like Valium and Librium. You heard those words before? Okay, those kinds of medications, those are benzodiazepines. And in older adults, they last in the system a lot longer and they can cause a kind of mental confusion simply because they're lingering too long in our systems. Sleep disorders. Obstructive sleep apnea is associated with a brain dysfunction, okay? When you have a baby that's born, you have a cord wrapped around its neck, it suffers from a lack of oxygen, right? Sleep apnea is just that. Your brain is not getting oxygen because you're not getting any air. Okay, so if you have sleep apnea, you've been told you had sleep apnea, get it treated. There are surgical treatments and there are devices that you can use. Okay, diabetes, which goes along in this category, which goes along with this one too. It accelerates atherosclerosis. Thyroid disease, underactive and overactive thyroid can create a problem. Thyroidism causes atrial fibrillation. Atrial fibrillation causes little mini clots, and those little mini clots can go to your brain and cause a stroke. Okay, head trauma, self-explanatory, and we look for vitamin deficiencies because severe vitamin deficiencies do manifest as a type of dementia. So what are some of the things that protect your brain? Okay, as I said earlier, we're looking at brain dysfunction or Alzheimer's as a life course disease. So the more education you can get, and I'm not talking about going to college and getting a PhD, I'm talking about getting as much literacy as you can, at least finishing high school. So we want our young people to finish high school, at least. Okay, formal training in music and language. People who are brought up in homes where they speak more than one language, this is good because this puts money in your bank to use later on as you get older, because you have more routes to use, if you will, if something becomes dysfunctional. Exercise, moderate aerobic exercise, 150 minutes a week for everybody is something that's good. Why? What's good for your heart is good for your brain. It lowers your blood pressure, but more importantly, it improves blood flow to the brain. All right? Anti-inflammatory drugs, okay, aspirin, ibuprofen, antioxidants, you're going to talk about this. Inflammation is one of those things that affects the blood vessels that subsequently affect the brain. So you want to avoid inflammation. And that's where the arthritis comes from, things like that. So aspirin is a stroke preventative, ibuprofen, antioxidants, you're going to hear about that. You can buy them in a bottle, you can buy them in a jar, but the best thing to do is to just eat them. So more green, fresh vegetables, fruits, things like that. Statins, they protect against cardiovascular disease, the strokes. Red wines, red wine because of their antioxidants. Social engagement. So people who are socially isolated have a tendency to have more signs and symptoms consistent with impending brain dysfunction than people who do not. Those of you who came here today, you're socially engaged, maintain that social engagement. If you have bridge club, if you are a part of a sorority, if you golf, if you go fishing, whatever it is that gets you in front of other people more than yourself, more often than not, is good. Okay? Hearing loss. Last year we had one of the ear, nose, and throat doctors talk about how hearing loss is implicated in brain dysfunction. So this is one of the things that we can do. So when we're in our 60s, our 50s, we should all get a hearing test. We should all start working on our hearing loss because that's how we interpret the world, just like we get our eyes examined. Okay, managing and treating depression, managing chronic diseases, chronic hypertension, diabetes, and heart disease, getting enough sleep. Aside from sleep apnea, more of us need to sleep a little bit longer. If you read any of the commercial journals, Ladies' Home Journal, Cosmopolitan, I'm trying to think what else have I read recently, Marie Claire, I mean, they're all talking about the importance of sleep. All of us, not just babies, need at least 8 to 10 hours of sleep a night. So getting good sleep. So the people who say, I do really well with like 4 or 5 hours of sleep, they're lying. Okay? Everybody needs to sleep. If you're napping during the day, not because you meant to take a nap, but because you're falling asleep at your computer, you need to get a little bit more sleep at night. Maintaining a healthy body weight. Being overweight is associated with some of the risk factors that lead to brain dysfunction. And then when people say, well, what sorts of things should I eat as I get older? What's supposed to be good for my brain? Well, again, I'm going to say this again. What's good for your heart is good for your brain. So low fat, monosaturated fats are bad for you. So olive oil, fish, poultry, leafy green vegetables. Now they have something, we like Mediterranean diet, but there's something now called a MIND diet, which is a combination of the Mediterranean diet and the DASH diet, which is the heart healthy diet. How many of you are familiar with that? Okay, when I can't remember anything, how many of you are familiar with MyPlate? The new dietary recommendations? If you can't remember any of this, just do the MyPlate thing. The simple thing is you draw a circle, that's your plate. You cut it in quarters. Half of it has to be leafy and green and live, and maybe 1/4 of it needs to be a protein. Not a fried chicken, not a fried fish, okay? But a lean protein, all right? And you can have grains in there, but just do the MyPlate. MyPlate.gov, they have a guide for older adults. They have one for young people, but the easiest thing is to draw a plate, make sure that half of it is green and leafy and otherwise unprocessed. Somebody might call that the ketogenic diet. You know, what is it, keto? We just eat meat and we just eat vegetables. I've tried that one too. Okay, so this is the pathology of Alzheimer's. Not that this matters a whole lot, but you're going to hear something about alpha, beta, or A beta proteins. That's the clumps or the plaques, and the tangles, which are accumulation of tau protein. These proteins, these are the pathology things that we look for in medicine underneath the microscope. These are the things that go along with Alzheimer's disease. As research progresses, we find that there are other things that may be associated. We did know a long time ago that the only way you could see these plaques and tangles was if you died. But now we can see them on a PET scan, so we can see them in vivo in living people. And there's a special scan that has been developed to look for this amyloid in living people, but it's $6,000 a scan. Medicare's not paying for it. But in research around the country, they were giving PET scans to people who might be at risk. And it's a non-invasive, means we don't stick you or probe you. We can just do an x-ray to see whether or not you have Alzheimer's, because we can identify these proteins under that scan. This is an autopsy specimen. This is a healthy brain. See how pretty it is? See how nice and fit together it is? And this is a brain with Alzheimer's. So what do you see between here and here? You see lots of atrophy or brain shrinkage. That's where all these little channels get a little bit deeper. And then right here, this is what they call the hippocampus. This is what we look at on MRIs now, and this is what we look at in autopsy. What does their hippocampus look at? See, this is all full here. Absence of a hippocampus usually means, or shrinkage of a hippocampus usually means Alzheimer's until proven otherwise. Almost always, these are the pathologic things that we're looking for. So when you start looking at a diagnostic thing, what are we looking for? When we do a brain image, we're looking at this area in particular. Lots of older brains are going to have atrophy, but we're looking for the absence or the shrinkage of the hippocampus. That's a diagnostic sign for Alzheimer's. What are the stages of Alzheimer's? They have 1, 2, 3, 4, 5, 6, 7, any kind of number you want. But I like to look in terms of function, because I think people understand function better. Function tells me when somebody has to have help. Function tells me what kind of help I need to get for them. So if I'm up here with mild cognitive impairment and I'm able to do for myself, I don't really need a whole lot of assistance, right? As my dementia progresses, maybe I forget things, maybe I don't forget things. As long as I'm able to do what everybody else does by myself, I probably don't need much help. But I probably do need you to start paying attention to my bank account. I probably do need to make sure that you're paying attention to me. If you start to notice that I'm wearing the same clothes over and over again, even though they're soiled, you might want to take a look at what's going on in my house. If my house has always been neat and clean and now all of a sudden it's not neat, Mama, why don't you clean this up? And she's never been messy before, that's a warning sign. That's a trigger in my mind that you need to look a little bit closer. Okay? Some people have worsening memory. As dementia progresses, their memory worsens, they need more support, they have functional limitations. Remember I said a lot of people with dementia don't walk well, right? They fall a lot. People who are starting to have more physical difficulties need more assistance. As your dementia progresses, you get to the point where you don't remember a lot of things, you have no abilities really to manage yourself or take care of your basic needs, so somebody else has to do that for you. And maybe you've become irritable and you're disagreeable. But more importantly, if you're living by yourself up here, now you're getting to the point where you can't really live unattended. Somebody's got to either come in there and be with you, or they have to move you out and put you someplace else. When you get to the point where you can't do anything for yourself between the moderate and the severe stage, you're either living with your relatives, or if you have the resources, you're in a, I don't like to say assisted living. You know why I don't like to say assisted living? How much does assisted living cost? You said $3,000, okay? In Metro Atlanta, within 285, it's more like $5,000 a month for the memory care unit. Most people can't afford that. Some very wealthy people can, but when you start to have problems and they say, well, let me put you into assisted living, I've got long-term care insurance. Most long-term care insurance isn't going to last indefinitely. There's a finite amount of time that this stuff lasts. So we've gotten to the point where we're starting to figure out better ways to live with people who have this disorder. Most people with this disorder, whether it's up here or down here, where do they live? They live at home with somebody. All right, and if you've got a big family, my husband has a big family that used to live in the country, and all the people in the neighborhood, in the community, that's what we call it in the country, right? The community, they helped everybody. We don't live like that anymore. Most of us live in Metro Atlanta and we don't know our next door neighbors. And our next door neighbors aren't likely to come over and sit with you for a while. Some people have good neighbors in neighborhoods where they do that, but most of us don't, because we live in bigger houses where we live further apart from each other. So how do we do this? What do we do if we're 65? How do we screen? What do we do? Well, the annual wellness visit is something that your Medicare pays for, that our tax dollars pay for, and you have no copay, and this is where you basically get all the preventive things done that you need to have done. And it's not just about Alzheimer's, it's checking your immunizations, checking your vision, making sure that you've done all the screening exams for cancer, making sure we get you scheduled for that hearing test that's important, managing all of these things if you haven't been screened for diabetes, to look for those things. And most importantly, during your annual wellness visit, because we do this every year after age 65, we do a dementia and depression screening. Why do we do depression screening? Why? Because I said depression is one of those things that's fixable, right? And it frequently masquerades as a dementia. So we do a dementia and a depression screen. So let's just say your dementia or your depression screen is abnormal. What do you do next? Does that give you a diagnosis of Alzheimer's? No. All that means is we need to do a little bit more investigation. If you have an abnormal breast exam and you feel a lump, does that mean you have breast cancer? No. That means you've got to go get a biopsy, you've got to do additional imaging. You need to have more information before we can give you that diagnosis, right? Same thing with dementia. If you have a screen that's abnormal, all that means is that a little bit more investigation is required. So what do you generally do? Okay, we do a screen in the doctor's office. This screen is usually a 5 to 10 minute test that's done in a primary care doctor's office. Again, that's not diagnostic. If it's abnormal, it just means that more stuff needs to be done. So what is some of the stuff that needs to be done? We have to do a comprehensive medical exam to make sure that you're on the right medications for the right disorder and that you're not having a medication interaction. We need to do a medical history and make sure that all your diagnoses are correct and you're being treated properly. We need to make sure that any chronic diseases that you might have are being managed as well as they can be. And then we check for things like this. If you've never had a diagnosis of diabetes, thyroid disorder, we look for that. And yeah, we still look for syphilis and we look for vitamin deficiency. So we're going to check a vitamin D level, a vitamin B12 level. And then in addition to making sure that all this part is right, your primary care doctor is the one who's going to order your brain MRI. I put the amyloid PET scan up here because the neurologists and the people who work in super research centers have access to this. But most of us don't have an amyloid PET scan. You're not going to find one in Albany, Georgia. You're just not. Okay, you're going to come to a research place where you're going to find this. But you will probably have an MRI in a local regional medical center. And then there's neuropsych testing. I like to call this the intelligence test for older adults. It's a pen and paper test where you do trails, you make pictures, and they look to see whether you can recognize things. And then finally, in our center, and most centers, we'll do a spinal fluid examination. Why? Because those proteins I talked to you about, the A beta or the A beta protein in tau, precursor proteins are found in your spinal fluid. They're not in your blood yet, but they are developing tests where we can do this in your blood, take blood from your arm to do it. But when you have a screen that's abnormal, chances are you have to have all of these things done. And once we have all of these things done, we can give you a better idea of what's causing the brain dysfunction. If you go to a neurologist, and I will tell you that at Emory, if you're going to see an Emory neurologist, until you have had a comprehensive medical examination and clearance by your primary care doctor, you're not going to see a neurologist. You're going to see a nurse practitioner who's going to do all of this, and then you'll get to see the neurologist, maybe. So the working way we do things at our Emory outpatient center for neurology is your best referred in by your primary care doctor, and it's assumed that this doctor has done all of this and gotten the imaging, and when you have that information to present to the neurologist, he or she can determine what other things need to be done. There's no treatment, I've told you that before. Current medications that we use for Alzheimer's and other dementias are the same regardless of what anybody says, and we combine them all kinds of ways to try to alleviate some of the symptoms, but none of these medications are curative. If somebody's got behavioral problems and they're disruptive and maybe they don't sleep well, they may be put on an antidepressant. It's like, well, why do you want to put them on an antidepressant? They're not depressed. Well, a lot of people do have depression that goes along with this, but more importantly, these medications can help people sleep, then can help improve their appetites, and they're less, they have fewer side effects or problematic side effects versus these medicines like Risperdal, Seroquel, and Geodon. And in nursing homes, unless you have a psychiatric disorder that requires those medications, those are things that we don't like older adults to be on because they make them sleep all the time. And if they sleep all the time, they don't eat and they don't drink. And what happens when that happens? They get dehydrated, and when they get dehydrated, what generally happens? They get a 911 call and they go to an emergency room someplace, they get IV fluids, and then they send them right back to get it all started all over again. That's some of the unnecessary hospitalizations for people with dementia. So these are usually chemical restraints when used in a nursing facility, and you know, we've learned in dementia care that if you redirect people, there are behavioral things that you can do to control people's behaviors. In any event, I do want you to appreciate that dementia or brain or neurocognitive disorder is not a normal part of aging, and different types of neurocognitive disorders have different etiologies. There's generally no cure for any of these neurodegenerative processes. At age 65, you have an annual wellness exam. That's not a physical exam where you take off all your clothes. The only physical thing is your weight and your blood pressure. You want an annual wellness exam, which is your personalized health plan, to screen, which allows for an annual screen of memory and mood and other things to keep you healthy. Some dementia symptoms may be caused by things other than a dementia, but may be caused by medication interactions, chronic illness that's not well controlled, heart or lung disease, and untreated mood disorders. The important piece here is that until we develop more research, we have currently no medical cure for dementia. Let me read that again. There is no medical cure for dementia, so I don't care what somebody sells you. They can sell you some antioxidants, but I told you you can eat those. Okay, medications in use right now treat symptoms only, and currently we need research, more research needed to better understand not only the disease, but more importantly, normal aging. What is it that keeps us aging well and living with most of our faculties to the end of our days? This is the focus of most of the research in brain health now. You'll hear us say brain health. You didn't hear me say Alzheimer's. We're going to talk about brain health. And brain health is keeping you healthy, and it's a preventive stance in research now. So we're looking at more preventive strategies versus curative strategies, because we have to go back not at 85, we've got to go back to 35 and 20, because this is a life course disease. Questions?
Is this an epidemic yet for brain diseases of the elderly?
They're calling it an epidemic, and they're calling it tsunami. Why? Most of us in here are baby boomers, right? Okay, we're the greatest generation because we're the biggest generation, right? As this big generation ages, we're not dying like our parents did. We're still living. So it's becoming an epidemic because it's affecting more of us, because more of us are living longer, and we're developing these symptoms. You know, your grandparents, probably most of our grandparents didn't live beyond 75 or 80. Most of them died in their early 60s. Now we have people living, the fastest growing population are the people over 100.
What about, you say you need sleep, but then what about drugs like Ambien?
That's the crazy medicine. Okay, those are like benzodiazepines. I think that we have a whole area of medicine called sleep. And if we are having difficulty with sleep, part of what the sleep doctors do is make sure that there's not a physiologic cause for people having difficulty sleeping. And then for a lot of us who have sleep disorders, aside from a medical problem, a lot of it's emotional, you know? We do suffer from stress. We do suffer from a certain amount of anxiety that doesn't let us unwind and let us go to sleep. So those are the 4 and 5 hour people who don't need 10 hours of sleep, okay? But Ambien, it's a chemical, right? And in older adults, Ambien, you know, sleep medications, I'm trying to think of another one. There's another one that's very popular. Sonata. Ambien, there's one that begins with an L. That may be it, but the point of this is older adults don't need to be taking those medications. Even younger people can have side effects, cognitive side effects that are related to those medications. So if you're having sleep problems, we need to make sure that your sleep hygiene is good and that there's not a medical reason for you having difficulty sleep. Sleep apnea is another reason for people not to sleep well. So see a sleep doctor simply to make sure that you're having sleep that's not related to a physiologic problem rather than an emotional problem. And just throwing medicine at it isn't going to make it go away. Things that make you go to sleep better are things like exercising up during the day, getting up, making sure you have a proper circadian rhythm. Exercise helps all of that.
What age do you recommend going to a geriatric doctor?
If you can find one. By definition, a geriatric doctor takes care of people age 65 and older. I will say to you that most clinicians, experienced clinicians, good internal medicine doctor, good family medicine doctor, who may not be a geriatric doctor, is a geriatric doctor because that's all they take care of. But in terms of certification, I think in our culture we get all bent out of shape about that. But if you have a good primary care clinician who listens to you and is paying attention to what's going on, that's good. But if you live in Metro Atlanta, you can probably find a geriatric doctor. But if you live in Albany, you might not find a geriatric doctor, right? So what about all those people who live down there? Or what's another place that I like? Dublin? Okay, that's kind of far away, isn't it? And just because you live near Savannah or near Medical College of Georgia, you're more likely to find a geriatric center or geriatric focus practice. The family medicine training programs at Mercer, in Macon, at Columbus, or up in Rome are more likely to be geriatric friendly versus people who are not associated with those training programs because they have special modules, internal medicine does too, for geriatric care and training. Yes, ma'am.
With regard to the different stages of dementia, is there an average time frame that a patient would move from one stage to the next?
We used to say that, but most people who have Alzheimer's, you know, we used to say from the time of diagnosis to the time of death, it can be 8 to 9 years. But there are people with a diagnosis of Alzheimer's who've lived for a good 20 years beyond what their original diagnosis is. Everybody's an individual, and that's what we're learning with Alzheimer's. And I think that the earlier you are in this evaluation and this diagnostic process, people with advanced dementia who haven't been managed or cared for generally die from the things around their dementia. You know, I've had dementia for a long time. I'm not eating, so I might die from malnutrition. I might die from an opportunistic infection because nobody's paying attention to my overall health. But if you're in good health, you can live for a long time with dementia.
Specifically ask your PCP for a wellness exam versus a physical exam?
Okay, I want you to go to Medicare.gov and look up the wellness exams. They're screening exams, and each one of them has a special diagnostic code that the doctor is supposed to use to allow you to screen for that. Now, if you go to your doctor every year at age 65 and you already know you have high blood pressure and you've got diabetes and you go see him every 3 months for that, when you go for that wellness exam, that's not there to manage your high blood pressure and your diabetes and get a renewal of your prescription. You go out to the front desk, you pay your copay, and then you come back and get that medication. But the annual screening exam, there's special screening codes at different, you know, we've been doing these coding workshops for doctors for a couple of years now to show us how we can get paid for that. And if you do an annual wellness visit properly, instead of getting your little $66 if you get that, more like $30 for a doctor's office visit. You can get anywhere from 170 something to, a wellness visit is like $178 for an wellness visit. And welcome to Medicare visit is like 200 and something, which is good for the doctor if they code it properly. And then we make arrangements for you to get those laboratories with the right codes that don't come out of your pocket.